Okay, my friends, good morning. Let's talk about aspergillosis. So I'm Dr. Armen Astvatsatryan, professor from Armenia. Not for you, Dr. Y. So let's talk about aspergillosis or allergic bronchopulmonary aspergillosis, ABPA, but just aspergillosis. Allergic bronchopulmonary aspergillosis, ABPA, so once again, just aspergillosis, is a hypersensitivity reaction to aspergillosis species, generally Aspergillosis fumigatus, that occurs almost exclusively in patients with asthma or, less commonly, cystic fibrosis. Immune response to Aspergillus antigens cause airway obstruction and, if untreated, bronchiectasis and pulmonary fibrosis. Symptoms and signs are those of asthma with the addition of productive cough and occasionally fever and anorexia. Diagnosis is suspected based on history and imaging tests and confirmed by aspergillosis skin testing and measurements of immunoglobulin E levels, circulating precipitants, and Aspergillosis fumigatus specific antibodies. Treatment is with corticosteroids and, in patients with refractory disease, itraconazole. Allergic bronchopulmonary aspergillosis develops with airways of patients with asthma or cystic fibrosis become colonized with species of aspergillosis, ubiquitous fungi in the soil. Ubiquitous fungi in the soil. Ubiquitous fungi in the soil. About pathophysiology of aspergillosis. For unclear reasons, colonization in these patients prompts vigorous antibody immunoglobulin E and immunoglobulin G, and cell-mediated immune response type 1, 3, and 4, hypersensitivity reactions to Aspergillus antigens, leading to frequent recurrent asthma exacerbations. Over time, the immune reactions combined with direct toxic effects on the fungus lead to airway damage. So effects of the fungus lead to airway damage and with dilation and ultimately bronchiectasis and fibrosis. The disorder is characterized histologically by mucoid impaction of airways, eosinophilic pneumonia, infiltration of alveolar septa with plasma and mononuclear cells, and an increase in the number of bronchiolar mucous glands and goblet cells. Rarely, other fungi, such as Penicillium, Candida, Calvularia, Helminthosporium, and Drexilera, cause an identical syndrome called allergic bronchopulmonary mycosis in the absence of underlying asthma or cystic fibrosis. Aspergillus is present ultraliminally but is not invasive. Thus, aspergillosis must be distinguished from invasive aspergillosis, which occurs in immunocompromised patients, aspergillomas, which are a collection of aspergillus in patients with established cavitary lesions or cystic airspace, aspergillosis pneumonia, which is rare and occurs in patients who take low dose of prednisone long term, for example, patients with chronic obstructive pulmonary disease, COPD. Although the distinction can be clear, overlap syndromes have been reported. Symptoms. Symptoms and signs of aspergillosis. Symptoms, ABPA was just aspergillosis. Symptoms and those are those of asthma and pulmonary cystic fibrosis, exacerbation with the addition of cough productive of dirty green or brown plaques and occasionally hemoptysis, fever, headache, and anorexia are common systemic symptoms in severe disease. Signs are those of airway obstruction, especially wheezing and prolonged expiration, which are indistinguishable for asthma exacerbations. Diagnosis. Diagnosis: history of asthma, chest X-ray and high-resolution computer tomography, skin prick test with Aspergillus antigen, Aspergillus precipitans in blood, positive sputum culture for Aspergillus species or rarely other fungi, immunoglobulin E levels, blood eosinophil count. The diagnosis is suspected in patients with asthma with recurrent asthma exacerbations, migratory or non-resolving infiltrates on chest X-ray, often due to atelectasis resulting from mucoid plugging and bronchial obstruction, evidence of bronchiectasis on imaging studies, sputum cultures positive for Aspergillus fumigatus or notable peripheral eosinophilia. Several criteria have been proposed for the diagnosis, but in practice not all criteria are assessed in every case. When the diagnosis is suspected, a skin prick test with Aspergillus antigen is the best first step, but serologic testing for Aspergillus precipitans may be a more practical initial test. An immediate wheal and flare reaction should prompt measurement of serum immunoglobulin E, and Aspergillus precipitans becomes up to 25% of patients with asthma without Aspergillus may have a positive skin test. An immunoglobulin E level more than 1000 nanogram milliliter and positive precipitants suggest the diagnosis, which should be confirmed by measurement of specific anti-Aspergillus immunoglobulins. Up to 10% of healthy patients have circulating precipitants. When Aspergillus is suspected, a finding of Aspergillus fumigatus specific immunoglobulin E and immunoglobulin G antibodies in concentrations at least twice those found in patients without Aspergillus establishes the diagnosis. Sputum and bronchoscopic cultures for Aspergillus have a low sensitivity and specificity for the diagnosis of Aspergillus and are not included as diagnostic criteria. Whenever test results diverge, such as when serum immunoglobulin E is elevated but not Aspergillus fulmingatus specific immunoglobulins are found, testing should be prepared and the patient should be monitored over time to definitively establish or exclude the diagnosis. Treatment of Aspergillus, prednisone, sometimes antifungal drugs. Treatment is based on disease stage. Stage 1 is treated with prednisone 0.5 to 0.75 milligram kilogram orally once a day for 2 to 4 weeks, then tapered over 4 to 6 months. Chest X-ray, blood eosinophil count, and immunoglobulin E levels should be checked currently for improvement, defined as the resolution of infiltrates. More than 50% decline in eosinophilus and 33% decline in immunoglobulin E. Patients who achieve stage 2 disease require annual monitoring only. Stage 2 patients who relapse stage 3 are given another trial of prednisone. Stage 1 or 3 patients who do not improve with prednisone stage 4 are candidates for antifungal treatment. Itraconazole 200 mg orally twice a day for 16 weeks is recommended as a substitute for prednisone and as a corticosteroid-sparing drug. Itraconazole therapy requires checking drug levels and monitoring liver enzymes and triglyceride and potassium levels. All patients should be optimally treated for other underlying asthma or cystic fibrosis. In addition, patients taking long-term corticosteroids should be monitored for complications such as cataracts, diabetes mellitus, and osteoporosis, and possibly prescribed treatments to prevent bone demineralization and pneumocystis jirovecii lung infection. So, pneumocystis jirovecii lung infection. So, about key points, and that's largely enough for this aspergillosis. So, consider allergic bronchopulmonary aspergillosis. If we have to consider allergic bronchopulmonary aspergillosis if a patient with asthma or cystic fibrosis develops frequent exacerbations for unclear reasons, has migratory or non-resolving infiltrates on chest X-ray, evidence of bronchiectasis on imaging studies, persistent blood eosinophilia, or if a sputum culture reveals aspergillus. So begin testing with a skin prick using aspergillus antigen, followed usually by serologic testing. Treat initially with prednisone. If aspergillus persists despite prednisone, treat with antifungal such as itraconazole. So that's enough. That's all about allergic bronchopulmonary aspergillosis, ABPA, or aspergillosis. Thanks for your attention. Don't forget to subscribe and follow our channel and put the ring on to be in touch with all news from Dr. Y. And please don't forget to make your donates. It will be highly appreciated. How to make these donates you can find in description of this video, in YouTube or in podcast, or you could use just directly YouTube possibilities, making a sponsor to be sponsorship of our channel. Why not? So thanks a lot.